Okay, so why don't you, should I just give you a cue like I could do this, Chris? Or
You can just say next, and then I'll scroll.
okay, so advance it. So just a little bit about my background. In terms of multifamily, is that my core work in this work has been through a National Institute of Mental Health grant. Back in the day, it's been quite a long time now, and I was a clinician first and then a supervisor of the work. And Dr. Bill McFarland is the originator of this work, and I've continued to work with he and his team out of Peer Institute, which is in Portland, Maine. So I've been able to train and clinically supervise a number of teams, not much in Washington after we did the Spokane review, but in Montreal, Canada, and in California, a number of teams in California, primarily in the San Francisco area, some in San Diego, and then Utah, and also Idaho. We've adapted this model after we did the work with the original model with multifamily. We actually took a look at thinking about adapting the model to other populations that had chronic conditions. So we adapted the model to spinal cord injury and traumatic brain injury, and we rolled this out in Spokane and found it to be fairly effective and helpful to families. And so we did a little publication on that work, and then we're contacted by the VA in New York City, and we did some work with the VA in New York and Atlanta, Georgia. And what we found with families who had persons coming back from the Iraq war in terms of having brain injury issues. And also both of those adaptations were found to be helpful to families and also persons with the injuries. So I'm really committed to this work, and that's why I continue to be so enthusiastic about it. And some of you who have heard me talk about it in PACT know that I'm a real zealot for multifamily because I've seen how effective it can be with people, in particular with schizophrenia. I've also worked with people with depression, diabetes, and also bipolar. So again, it has kind of a broad utility for different mental health diagnoses. Okay. So what are some of the benefits? I know that it's a struggle in PACT because many of the clients don't have a lot of connection or no connection with families. And yet what I discovered when I was working at Eastern State Hospital, and clients would say this to me, is that if you started to kind of dig a little deeper, sometimes you could find a connection. So, and maybe that's been your experience as well, is that there may be someone in the person's life. But we do recognize that for PACT clients that it can be a challenge. But for those clients who have families, clients sometimes are asking their families for support. So it's also helpful to be able to provide those families with the kind of support that they need. It also creates a larger social network for the family and the client. And families are sometimes isolated, many times isolated. There's a stigma related to this illness that many times cause people to pull away and not talk very openly about it with other family members or other of their friends or their community. As well, we know that many times families are not as informed as they might be about the illness, and they need support. So this collaboration, what we have found is the collaboration helps everyone, is that if you can connect with families, partner with the family and the client, what we've seen is that it really assists in the overall treatment. You are teaching families and clients skills in psychiatric rehabilitation, and when we talk a little bit about the group work, the focus of the group work really is a psychiatric rehab model. And then, of course, there's a lot of studies that have been done that would indicate that overall there is client improvement. And with clinicians, you see better outcomes, which can certainly be encouraging when you're working with a population that has such a long-term kind of process, long-term struggles. Okay. So there's a single family approach that was developed by a woman named Carol Anderson. And then Bill McFarland came along and he said, what if we did this with a group of families? And so the multiple family group approach has been the one that we have worked with. And I've done a lot of training in this area. But I would say that single family work also has been helpful to many families. So as you're thinking about potentially utilizing this, I think what you would find is that if you don't have a lot of families, you might start with a single family approach. But what we're talking about today is really a multiple family approach, which also includes families. And how it's, I think, different than many kinds of interventions with families and persons in particular with schizophrenia or severe and persistent mental illness is that it does include the clients. So it seeks to engage families in rehabilitation and recovery and really invite them in and value the kinds of experiences they've had and value the kinds of knowledge they have about their family member. And as I said, it creates this working partnership. It provides families and clients with information needed to understand the illness more thoroughly and from a kind of a more of a biological perspective. It also assists with developing social supports and expanding that network. And overall, because it has this psychiatric rehabilitation orientation, it helps families figure out ways and clients to figure out ways to adapt and have adaptive strategies to manage the illness. Very briefly, what do the clinical trial findings say? In over 30, now almost 40 studies that have been done on multifamily by the model, as I said, has been developed by Anderson, Falloon, McFarland, Goldstein, and others. You'll find a lot of names now that have really looked at this work. One of the biggest things that it reduces annual relapse rates for community-based clients with schizophrenia by almost 50%. There's a number of studies that have been able to actually replicate and find those same findings, which actually, if you think about it, is pretty significant. It also reduces hospitalizations. It increases adherence to medications. It improves family well-being and increases patient or client participation in rehabilitation. And I think an interesting piece, one of the studies that Bill McFarland did was adding multifamily onto PACT teams, and what he found is that it increased employment rates. Also, it decreases psychiatric symptoms, and in our study we found that it actually decreased negative symptoms pretty significantly. It also decreases medical illnesses and medical care utilization for families. That was another piece of our study in that we took a look at how many families, it was their connection between family illness and an increase in symptoms of the person with the illness. And what we found is that the kinds of infectious illness, colds and flus, were correlated with a person with the mental illness when they had a relapse. And over time, what we found is that those kinds of illnesses on the part of family members were reduced, likely because of reduction of stress and anxiety. And so, of course, that means reduction of cost of care, not only for the client by staying out of hospital, but also by the family for having less medical issues. So that was an interesting piece, I think, of our work. So what are the core elements of family psychoeducation? You're trying to provide education to at least 5 or 6 families and clients about the biological nature of schizophrenia, or put in the diagnosis you want to work with, and the principles for the management of that particular kind of diagnosis. So whether it be schizophrenia or bipolar or depression or diabetes or brain injury or spinal cord injury, you can develop an educational package about what is the best practice, what is the best kind of management to do with that particular diagnosis. Clinicians align with consumers and family members as partners in treatment. And I think this is about the 3rd time I've said that now. It's a really important piece, is to be able to partner with those families and to help them begin to sort of think about the person with illness the way you are thinking about them in terms of what might be the best kind of care. So after you provide some education and you connect with those families in a joining process, there is a 1-day educational workshop at the beginning of the program. And that is it. You have kind of an educational workshop that is formal, more of a training sort of design. And then after that, the education that you do is really weaved into the multiple family group itself. This intervention is longer term. It goes from a minimum of 9 months. And the reason why a minimum of 9 months is that the data would indicate that it takes about 9 months for there to be changes on the part of the client and changes on the part of the family. So before that, this is a slow process for sometimes for families to sort of pick up on this as well as clients. And that is why it's really important to sort of hang in there for 9 months. The work that we did was 2 years, and generally most of the groups that I've supervised have been up to 2 years. There is support and problem solving experiences are provided in the group. There's ongoing education about medication and about community support and work. And again, that's weaved into the discussion. So overall, what you're trying to do is assist families and consumers in improving their coping and problem solving and communication skills. Okay. And medication is followed closely. As you can see, if you would have a multiple family group and then you also would be doing work with the client individually, you have many opportunities to really track that medication. So there are 4 stages of the work. There's recruitment, of course, and then there's a piece called joining. And this is when you would be working individually with consumers and families and trying to gather information and also develop a trusting relationship with that family. In PACT, many of you know, of course, you know the clients and many of you know the families. So you have some of that information already. I think one piece of information that I have found to be really helpful is to be able to identify with the client and with the family what those really early warning signs are that are moving a person towards a relapse. And because that is what you're going to be working towards in terms of trying to be able to use that information and in terms of helping a person be able to signal when they might be having difficulty and be able to do some kind of intervention and teach them about what our early warning signs look like. And you're also trying to help understand with the family what the symptoms look like. You're also talking with families about how they cope, what their social network is, and what they have done, how they have coped with living around a person with illness, or if it's the client, how they've coped with the illness. Then you conduct, as I said, the one-day educational workshop. And this is done by the team. So if a PACT team decided they were going to do this sort of intervention, the team would come together and probably the prescriber would talk about medications and team members would pick up other pieces of the educational workshop that is put together. It's already, there's an agenda that's designed. It's not something you'd have to put together yourself. You could add some things, but you're looking at etiology and medications and typical treatments, a little bit about the research, and also perhaps about your community resources in your local community. The next piece after that, which goes on then for the rest of the intervention, is the problem-solving group. And that's attended, as we talked about, by clients and families, as many clients as can come. Sometimes we know, of course, clients can't come, but as many clients as are able to come, we certainly encourage that. This is a structured sort of group process, and it runs for 90 minutes. So here's the structure of the problem-solving group. You do some initial socializing. One of the things that we have found in this work is that this is where you really help people, families, connect with each other. You help them connect the idea that it's important to have a life outside of this illness, because one of the things that we find is that families are so focused on the illness with their family member that it's difficult for them to kind of focus on anything else. But most importantly, you're really also trying to help the client learn about how to socialize. For people with schizophrenia, one of the things we know is that their social skills diminish with this illness. And what we've found has been really interesting to, if you dose in some ways a person with socialization, what we have noticed is that people with a lot of flat affect and negative symptoms began to make some changes. So socialization is really an important piece of helping develop that social network, develop social skills, and help people in the group really connect with each other. So then there's what's called the go around, and this is when you're sort of looking at how did the week go and what might be some warning signs and symptoms. You're listening for that kind of picture. You want to really hear if there are changes and what kind of changes there might be. You're looking for relevant biosocial information, and then family guidelines, which I'll talk about in a minute. So after you sort of each family, each group of families, so if you have 5 families, you're going around the room, you may have 15 to 20 people. There are 2 clinicians that do this work. So there can be a lot of people in the group, which is why having this kind of structure can be really helpful. So after you're kind of understanding what the issues might be, you select a problem to work on. And this is the clinicians really take control of this initially. And they really listen for things that might assist with helping the families, because many times families have pretty high expressed emotion, or there's a lot going on in the family. And many times you're trying to help the family kind of cool things out at home. You select a problem, and then you go through the basic problem solving process where you define what the problem is, you identify some solutions, you look at the pros and cons. Out of that, you take more pros, less cons. The family chooses a solution that they think would be most useful for them. They go home, you help them define who's going to do what, when, and where. They go home, they try it out, that's their homework. They come back and they report to the group as to how things went. This then over time, you begin to utilize these kinds of problem solvings as a treatment plan with the client. So over time, if something worked well, you want to really recognize, okay, this is a good thing to continue to do. And you support that client, you track what that solution was, and you keep talking about it and supporting it with the client over time. And then you come back together and do a final socialization for a few minutes. Okay. But here are the guidelines. So as you can see, these guidelines: go slow, keep it cool, give them space, set limits, ignore what you can't change, keep it simple. Those first 6 really have to do with trying to reduce the stimulation in the environment. The next, following prescriber's orders, carry on business as usual, no street drugs and alcohol, which of course we know is an approximation, not necessarily a rule, but we're working towards that. Picking up on early warning signs, solving problems, and lowering expectations are a part of trying to support the person in strategies that we know can be helpful to them. So one of the things I guess I'll also say about this is something that we start talking about on the first session with a family. It's talked about in detail in the workshop. And then as you get into multifamily, you're reinforcing these guidelines. When you hear a family did something that was going slower or keeping things cool or setting a limit, giving the person space, you really want to reinforce that. And so you, as well as when you hear someone being, when things aren't cool at home and when there's a lot of conflict possibly going on, you sort of try to remind people that kind of toning things down might be helpful. So these family guidelines really come out of, and go to the next slide, they come out of really altered brain function. So as we know, so that's our brief biology lesson for the brain for today, is that if you're looking at the prefrontal cortex, the activity there lessens due to metabolic and structural changes, which reduces abstraction and problem solving skills for the client. So this is also something we talk with families about, these 4 points in the educational workshop. And for many of the families I've worked with, this is sort of a new way of thinking about it. And we really try to lean on biology as much as possible instead of behavior, to help people understand there's a reason why people may be having difficulty with attention. We talk about the limbic system, which assists with attention and integration of thoughts and feelings, becomes overactive. And so when that's sort of happening, we try to remind people this is a good time to go slow and keep things cool. And then reducing activity in the cingulate cortex creates emotional lability and a
That
disconnect.
they hired her, and then they because some
Oh, we got somebody we can hear here. If you can mute yourselves, it'd be great.
And then the last one is the superior temporal cortex, which processes language and supports comprehension. It becomes less active. So there's a piece in the workshop where we show the brain and we talk about where these areas are in the brain and help families begin to sort of put the puzzle together about why are the behaviors of my family member, why do they keep doing these things, and really try to help them understand that this is a cognitive problem and a cognitive challenge. So, and then connect that back to how these guidelines then help actually cool out the brain and help the brain function in a way that is going to be more useful and not overwhelmed. And I think for a lot of families, they really begin to get this. They say, okay, yeah, I can see I have to function in a certain kind of way with my family member in order for them to not be too agitated. But putting it back to biology can be pretty useful. Clinicians. So it's been pretty clear that the kind of clinicians who make the best clinicians for this work are people who are can really exude a sense of warmth and be very collegial with families. And something that's not always easy for us is to be non-blaming of families. These attributes have the best chance of helping families learn new ways of responding to the illness. I have worked with lots of families that have been challenging. They've been known in the system to be challenging families, and it can be very hard not to sort of have your bias about these families because you've heard some things or you've heard a number of things, or I myself have worked with some of these families. What I have found, though, is that if I begin to sort of take the least pathology perspective and then try not to blame the families for what's going on and recognize that perhaps if they had more education and they began to learn some of the strategies that we're trying to teach them, there may be some changes made. And what we found in our study in Spokane is that is exactly what started to happen with a number of families. It was quite surprising. We would get feedback from other clinicians who were working with the clients that families were changing. The other thing that happened is that many of these families who had been complainers and had been actually having difficulty with the system and complaining to administrators had reduced that kind of behavior because they were actually getting their needs met in a different kind of way. So what we also understand is that our clinicians need active support. They need supervision. It's hard to do this work without some direction and supervision and some feedback about when you start a group like this. I know when I did what I know to do in terms of a group. This is a different kind of group. As you can see, there's a lot more structure to it, and there's a different kind of pace to it, and you're not doing therapy. You actually are doing education and support. So it has a different kind of perspective, and it's very helpful if you can get some supervision from people who've had experience in it. So translation and adaptation to PACT. These are just some ideas that I have had, and also they come from other teams in other parts of the country who have said, well, how do we really make this work in our system? So one of the best things, though, is to start with offering a full training to the whole team. And I say this because I think it's important for everyone on the team to understand what is multifamily, that it's not some kind of a secret. The other thing is that a lot of the concepts that are taught in the training are something that all team members can apply. And then with follow-up supervision for those who decide to facilitate the group. It's also helpful to have someone who's the zealot on the team that says, all right, this is my role, this is my job, and I'm going to focus on this area. And when you're thinking about, well, who would we work with, consider families who you currently might have some contact with. those that you think would benefit. It's also helpful to consider families that you hear from when there's a crisis. Those families make the best families because you can reduce the only hearing from them when there's a crisis and increase their engagement with you, as well as also teach them strategies that they can use so they can reduce those crisis contacts with you. Also, there are clients that I've worked with that if you really ask and begin to explore with them, they'll say, yeah, I really would like to talk with my family and reconnect with my family again. And that takes some time, patience, perseverance, but there may be some clients that you're working with that want to reinvest with their family or extended family. Also, we have done work with the landlord is the family support or the support person. The landlord is a significant other or other extended family or close friends. So you might kind of think more broadly as who are the support people in this person's life that we could invite into that process. You also, as I mentioned earlier, might consider a single family design and start there and begin to use these concepts with a single family. It would be helpful if you're going to do the work to hang in there for 9 months to a year. The other thing that I have done a lot of is as family, there are going to be possible family dropouts, and if there are family dropouts or withdrawals for whatever reason, you can add families. You have to sort of do that strategically, but it's possible to add new families. So this doesn't have to be a completely closed group, because I think if you consider it to be a closed group, you might get so small that it's not as effective as it would be. So preferably 2 families at a time, so they sort of feel like there's someone else coming in with me, and I'm not just the only family coming in. But it does work. We've had experience in it, and it's possible to do. It's also important to consider the cultural aspects. I've supervised a couple of groups in California that were fully Hispanic. And actually, Spanish was their first language, and so I had an interpreter when I was watching their videos. And it was a very great group. They did very well, and there was some nuances because of their culture that were added to the group. So it's also important to think about those cultural pieces. And also, one of the things that we did right from the beginning is that we started talking to the local NAMI group in Spokane, letting them know what we were doing, that we weren't competing with them, but that we were trying to enhance and augment the kind of support groups that they were doing. And that worked out very, very well and was a very positive kind of thing. And they began actually referring people to us that they thought might benefit. So having a relationship with your local NAMI organization, I think, is an important thing to do. Okay, question and answers.